Coagulation Test and Quiz Review. From the bleeding time questions: connective tissue diseases and von Willebrand disease are hereditary disorders that would cause an abnormal bleeding time. Bleeding time measures platelet function. A physician might order a bleeding time test preoperatively to screen for bleeding abnormalities. A critical value for bleeding time is greater than 15 minutes. The steps to complete a bleeding test are: properly identify the patient, label the filter paper, apply blood pressure cuff to the arm, inflate to 40 millimeters Hg, clean the patient's forearm with alcohol, make incision, start stopwatch. Every 30 seconds, apply filter paper gently to wound. Repeat every 30 seconds until bleeding stops completely. Deflate blood pressure cuff and remove from the arm. Document the bleeding time in minutes and seconds. Coagulation testing and platelets questions. Dense granules contain calcium, ADP, and ATP. Alpha granules are found in the organelle zone of the platelet. D-dimer, fibrinogen level, and APTT are all coagulation tests. Glanzmann thrombocytopenia is related to a deficiency in GP2B3A complex. The peripheral zone includes the platelet membrane, the open canalicular system, and the glycocalyx. Aspirin affects platelet function by interfering with platelet metabolism of cyclooxygenase. Alpha granules contain fibrinogen and platelet factor IV. Platelets are cytoplasmic remains of the megakaryocyte. A normal platelet count is 150 to 400,000 per microliter. A coagulation test should use an anticoagulant tube so the specimen will not clot. Coagulation Test 1. Platelet membrane glycoprotein 1b is the receptor for von Willebrand factor, which serves to mediate the adhesion of platelets to the subendothelium. The first step in platelet function after an injury is platelet adhesion to collagen. A substance released from platelets that promotes their aggregation is ADP. A nosebleed is epistaxis. Menorrhagia is increased menstruation. Petechiae is pinpoint hemorrhage. Hematoma is a bruise that involves swelling and can occur in organs and deep tissues. Thromboxane A2, a potent aggregating agent of platelets, mediates the platelet release reaction, precipitation, and adhesion, in addition to vasoconstriction. Platelet-to-platelet interaction is known as aggregation. Serotonin, thrombin, and ADP include specificities of plasma membrane receptors within the peripheral zone. The organelle region is responsible for the metabolic activities of the platelet. Von Willebrand factor mediates platelet adhesion by binding to platelet receptor GP1B, GP1X, GPV. Alpha granules, mitochondria, and dense granules are found in the organelle zone. The platelet membrane, open canalicular system are found in the peripheral zone. Actin and myosin are found in the sol-gel zone. The release reaction from dense granules involves the secretion of calcium, serotonin, and ADP. Platelet activity is affected by aspirin. Platelet activity is not affected by hyperglycemia, hypoglycemia, or anticoagulant activity. Primary hemostasis is defined as the interaction of platelets and the vascular endothelium in halting bleeding following vascular injury. Activation of platelets result in adhesion, stickiness, aggregation, and shape change. The minor system includes the complement system and the kinin system. The major system includes the serine protease inhibitors, fibrinolytic system, vascular system, platelets, and the coagulation system. 70% of the platelets are in the circulation. 30% of the platelets are found in the spleen. Von Willebrand factor is synthesized by endothelial cells and megakaryocytes. Collagen binds to platelets. Fibrinonectin is an adhesive protein for platelets, promoting spreading. Tissue factor is a lipoprotein released following vascular injury. PGI2 is prostacyclin that physically inhibits platelet aggregation and limits thrombus formation beyond the damaged cell. Platelets do not aggregate in Glanzmann's thrombocythemia when platelets lack GP2B3A. Cells involved in hemostasis are thrombocytes. The function of tissue plasminogen activator, or TPA, is to activate plasminogen to plasmin and lyse fibrin clot. The 3 steps of normal hemostasis in order are vasoconstriction, platelet aggregation, and fibrin formation. The blood vessel response to injury resulting in a breach in the blood vessel is vasoconstriction. Adhesion is a reversible process whereby platelets stick to a foreign surface. A normal platelet is 2 to 5 micrometers. The cells that line the central cavity of all blood vessels and related tissues are called endothelial cells. In the process of aggregation, fibrinogen binds to the calcium complex of a platelet membrane, GP2B3A. Platelet-stored products are released through the OCS. The steps in order are adhesion, then activation, then aggregation, and then release reaction. The lifespan of a platelet is 10 days. Exam 2 review. The coagulation factors of the prothrombin group are 2, 7, 9, and 10. The factors of the common pathway are 5, 1, 10, and 2. The factors in the intrinsic pathway are 9, 11, 7, and 8. PT and APTT measure the common pathway. APTT measures the intrinsic pathway. For 10A to convert prothrombin to thrombin, PF3, factor 3, and factor 5 are all needed. Factor 9 is also known as antihemophilic factor B or Christmas factor. Factor 13 is also known as fibrin stabilizing factor. Factor 1 is also known as fibrinogen. Factor 2 is also known as prothrombin. Factor 5 is also known as labile factor or proaccelerin. Factor 12 is also known as Hageman factor. Factor 10 is also known as Stewart-Power factor. Factor 7 is also known as stable factor or proconvertin. Factor 3 is also known as tissue factor. Factor 4 is calcium. Factor 8 is also known as antihemophilic factor A. Factor 11 is also known as plasma thromboplastin antecedent. The test used to measure platelet function is bleeding time. Factor 1 is a substrate. Thrombin acts on fibrinogen to split fibrinopeptide A and B from main molecule producing fibrin monomer and fibrin peptides. Factor 3 and 7 are the extrinsic pathway. PT measures the extrinsic pathway. The coagulation factors of the contact group are HMWK 11 and 12. The coagulation factors condemned in clotting are 8, 1, 2, 5, and 13. The coagulation factors that are serine proteases are 9, 2, 11, 10, 12, and 7. The coagulation factors that are transaminase is 13. Coagulation exam 2. Bleeding time measures platelet function. Mucous membrane hemorrhages are a characteristic of platelet disorders. The last stage involved in arresting bleeding after vessel damage is the formation of a stable platelet plug. Thrombin on the aggregated platelet surface converts fibrinogen to fibrin. With the exception of factor VIII, all the coagulation factors are produced in the liver. Factor IX is known as antihemophilic factor B. Factor VII is known as stable factor. Factor XII is known as Hageman factor. Factor I is fibrinogen. HMWK is Fitzgerald factor. Factor V is known as label factor. Factor IV is ionized calcium. Factor X is Stewart-Prower factor. Factor XIII is fibrin stabilizing factor. Factor XI is plasma thromboplastin antecedent. Factor VIII is antihemophilic factor A. Factor III is tissue thromboplastin. Factor II is prothrombin. Factor II, 5, 13, 1, and 10 are the common pathway. Factor 9, 8, 11, 12, HMWK are the intrinsic pathway. Factors 7 and 3 are the extrinsic pathway. The extrinsic system of coagulation is monitored by the prothrombin time. The intrinsic system of coagulation is measured by the APTT. Under control of the intrinsic pathway, factor 9A works with cofactor 8 and PF3 to activate factor 10. Factor 12 is activated to factor 12A. Factor 11A activates factor 9 to 9A in the presence of calcium. In the formation of a fibrin monomer, thrombin cleaves a portion of the alpha and beta polypeptides in fibrinogen to form fibrinopeptide A and B. Factor 5, PF3, and 4 are all involved in the conversion of prothrombin to thrombin in the common pathway. Factor 13 exclusively functions to create covalent bonds between fibrin monomers formed during the coagulation process to form a stable fibrin clot. The contact group of coagulation proteins includes HMWK, Hageman factor, plasma thromboplastin antecedent, and prekallikrein. The substrate of the coagulation system is fibrinogen. The prothrombin proteins are comprised of coagulation proteins. Factors are not consumed during coagulation. Factors are absorbed by barium sulfate or BaSO4. Factors are vitamin K dependent. Factor 8, Factor 1, Factor 5, and Factor 13 are all coagulation proteins that make up the fibrinogen group. The characteristics of the fibrinogen group of coagulation proteins. Factors are consumed during the coagulation process. Factors are not absorbed by BaSO4. Factors are increased during inflammation and pregnancy. High molecular weight proteins. The prothrombin proteins are comprised of factor 2, 7, 9, and 10. The characteristics of the prothrombin group of coagulation proteins. are that they are vitamin K dependent, they are absorbed by BASO4, and coagulation proteins are decreased in patients who are vitamin K deficient. The process of blood coagulation is a series of biochemical reactions that transform circulating blood into an insoluble gel through conversion of fibrinogen to fibrin. If there's a deficiency in any one of the coagulation factors, coagulation will not proceed at the normal rate. Bleeding from the injured vessel continues for a longer time. The time required for the clot to form is prolonged. Initiation of the next subsequent reaction is delayed. The correct sequence of events in hemostatic plug formation is adhesion, aggregation, plug formation, consolidation, and fibrin stabilization. Normal platelets have a circulating lifespan of approximately 10 days. A patient presents with a platelet count of 250 times 10 to the 9th per liter, or 250,000 microliters, and a bleeding time of 12 minutes. These results most likely suggest defective platelet function. A characteristic of Bernard-Soulier syndrome is giant platelets. Thrombocytopenia is a characteristic of May-Hegland anomaly. Manual PT laboratory questions. PT has become the basic coagulation screening test for diagnosis of congenital and acquired deficiencies of factors 5, 7, 2, and 10. The degree of prolongation is proportional to the severity of a single factor deficiency or an accumulative deficiency of all the factors involved. PT assays should be completed within 24 hours of collection. The INR is the patient PT over the mean of normal range raised to the ISI. The lower the ISI is for a given reagent, the more sensitive the reagent is to coagulation factors. Hemolyzed, lipemic, and icteric samples could cause interference when using photo-optical instruments. The presence of heparin as a contaminant in the patient sample must always be considered when an abnormal result is obtained. The ISI represents the comparative slopes between the new thromboplastin and the WHO reference thromboplastin. Exam 3 Review. Match the platelet surface glycoprotein to its adhesion point. GP6 binds to collagen. GP2B3A binds to fibrinogen. GP1B9B binds to von Willebrand factor. The INR reference range is 2 to 3.5. The bleeding time reference range is 1 to 9 minutes. The fibrinogen reference range is 200 to 400 milligrams per DL. The APTT reference range is 20 to 40 seconds. The platelet count reference range is 150 to 400,000 per microliter. The thrombin time reference range is under 20 seconds. The PT reference range is under 13 seconds. In the formation of a fibrin monomer, thrombin cleaves a portion of the alpha and beta polypeptides in fibrinogen to form fibrinopeptides A and B. The factors that are in the extrinsic pathway as well as the common pathway are 1, 5, 7, 10, and 2. Plasmin mediates the fibrinolytic system. The lifespan of the platelet is 7 to 10 days. Sodium citrate tubes are light blue in color and used for coagulation testing. Reptilase time is useful for patients on heparin. Russell's viper venom is used for the detection of lupus anticoagulant. D-dimer is used for the final product of fibrin degradation. Thrombin time is the time required to convert fibrinogen to fibrin. A normal platelet count is 150 to 400,000 microliters. Aspirin inactivates platelet cyclooxygenase. Prothrombin is converted to thrombin in the presence of factor 5, calcium, and platelet factor 3, or platelet phospholipid.
Early fibrin degradation products consist of X and Y monomer fragments. PT is affected by coumadin and warfarin. APTT is affected by heparin. Bleeding time is affected by aspirin. INR stands for International Normalized Ratio. The major contractile proteins in the platelet are actin. ISI stands for International Sensitivity Index. Late or final split products are D and E fragments generated from the breakdown of fibrinogen. Increased platelet count is the definition of thrombocytosis. The factors inhibited by antithrombin are 9A, 12A, 10A, 8A. Factor 10 is Stewart-Power factor. Factor 11 is plasma thromboplastin antecedent. Factor 13 is fibrin stabilizing factor. Factor 2 is prothrombin. Factor 5 is Labol factor or proacceleratin. Factor 4 is calcium. Factor 12 is Hageman factor. Factor 9 is antihemophilic factor B or Christmas factor. Factor 8 is antihemophilic factor A. Factor 1 is fibrinogen. Factor 3 is tissue factor. Factor 7 is stable factor or proconvertin. The Siamese twins of the coagulation factors are factor 8 and von Willebrand's factor. PT monitors the extrinsic and common pathways. APT monitors the intrinsic and common pathways. The functions of thrombin are to convert fibrinogen to fibrin, aggregate more platelets, enhance factor 5 and factor 8 activity, and activate factor 13. Fibrinolysis is the process of removing fibrin deposits in a gradual and progressive enzymatic cleavage of fibrin. Petechiae is a sign of platelet disorders. Coagulation Test 3. Thrombocytosis would be indicated by a platelet count of 600 times 10 to the third microliters because it's too high. A patient has been taking aspirin regularly for arthritic pain. Bleeding time is most likely to be abnormal in this patient. Platelet membrane glycoproteins is the receptor for von Willebrand factor, which serves to mediate the adhesion of platelets to the subendothelium. Actin is the major contractile protein in the platelet cytoskeleton that accounts for 20 to 30% of total platelet protein and functions within microtubules in organizing parallel filaments capable of contraction. Aspirin prevents aggregation of platelets due to inactivation of platelet cyclooxygenase. The coagulation protein assigned as factor 1 is fibrinogen. Factor 13 is the coagulation protein exclusively functioning to create covalent bonds between the fibrin monomers formed during the coagulation process to form a stable fibrin clot. The extrinsic system of coagulation is monitored by the prothrombin time. The factors involved in the conversion of prothrombin to thrombin in the common pathway are factor 5, 4, and PF3. Thrombin functions to convert fibrinogen to fibrin, activate factor 13, aggregate more platelets, and enhance factor 5 and 8 activity. The fibrinolytic system is mediated by plasmin. Fibrinolysis is the physiological process of removing unwanted fibrin deposits and represents a gradual, progressive enzymatic cleavage of fibrin to soluble fragments. Plasmin's inactive zymogen is plasminogen. Streptokinase, TPA, and urokinase activate plasminogen to plasmin. The final fibrin split products are 2D and 1E fragments generated from one molecule of fibrin. The function of plasmin is to destroy factor 5 and 8, destroy fibrin and fibrinogen, and produce FDPs. Patients with platelet disorders usually exhibit petechiae. Sodium citrate is the anticoagulant used in the tube for coagulation tests. Factors 7, 10, 2, 1, and 5 affect PT results. INR stands for International Normalized Ratio. ISI stands for International Sensitivity Index. The reference range for PT is under 13 seconds. Thrombin time measures the time required for thrombin to convert fibrinogen to fibrin. Reptilase time is good to use for patients on heparin. Russell's viper venom is a test to detect lupus anticoagulant. X and Y monomer fragments are the early fibrinogen degradation products. In the formation of a fibrin monomer, thrombin cleaves a portion of the alpha and beta polypeptides in fibrinogen to form fibrinopeptide A and B. The final product of fibrin degradation is the D-dimer. Laboratory screening in evaluation of bleeding disorder includes PTT, PT, and bleeding time. The factors inhibited by antithrombin are 12A, 8A, 9A, and 10A. The major portion of factor 8 is considered to be a carrier protein called von Willebrand factor. The intrinsic system of coagulation is measured by the PTT. The lifespan of a platelet is 10 days.
Manual PT questions. Once opened, the reagent actin FSL is stable for 7 days at 2 to 15 degrees Celsius. APTT has been widely advocated as a means to measure unfractionated heparin. APTT results should be reported in seconds. If unexpected abnormal APTT results occur, you should do additional coagulation studies following the test result. Low levels of antithrombin 3 can decrease responsiveness to heparin therapy. PTT will not detect qualitative or quantitative platelet disorders. Calcium chloride is stable after opening for 24 hours at 37 degrees Celsius. Calcium chloride is stored refrigerated and should be allowed to stand at room temperature for 30 minutes before use. Automated PT-INR quiz. Your PT tells a doctor the function of the blood clotting process. Some reasons your doctor might do a PT are if you're going for surgery, to monitor your blood thinner medication's effectiveness, or if you are having heavy nosebleeds and bruising. Heparin, vitamin C supplements, warfarin, and vitamin K supplements can alter your PT results. An INR is not measured during a PT test. The inherited trait that could cause a patient result to be prolonged is factor 7 deficiency. The acquired traits that could cause a patient result to be prolonged are liver disease, mild vitamin K deficiency, warfarin, and DIC. On the Stago analyzer, when the ball stops moving, it means a clot was formed. The reagent that causes the reaction to occur in a PT is tissue thromboplastin. Automated APTT questions. APTT looks at the intrinsic and common pathway. The reference range for APTT is 20 to 40 seconds. The factors that are not measured by APTT are 7 and 13. The therapeutic goal of APTT is 1.5 to 2.5 times normal. The additive used in order to be able to run an APTT test is sodium citrate. The ratio of anticoagulant to blood to be able to run an APTT test is 1 to 9. The kinds of reagents used while running a PTT are calcium dichloride, platelet phospholipid, and activator. An abnormal test result might occur from the specimen being taken from a lithium heparin tube. Coagulation Med Training Quiz. 1. To calculate the INR, one needs to know the ISI, the PT of the patient, and the PT of the normal pooled plasma. The equation is INR equals PT of patient over PT normal raised to the ISI. Due to the large variability of the thromboplastin reagent, PT values are standardized using the INR, or International Normalized Ratio. The ISI, or International Sensitivity Index, is a measure of how sensitive the reagent is to factor deficiency. The ISI is specific to each lot of thromboplastin and can be different among different lots made by the same manufacturer. The INR is followed in patients on warfarin. The target range is typically 2 to 3, depending on the specific underlying condition. An INR of 6 or above is associated with increased bleeding risks and should be avoided. 2. The lupus inhibitor causes prolongation of the APTT. The lupus inhibitor is associated with arterial and venous thrombosis and may cause recurrent fetal loss in women of childbearing age. It is usually an IgG that recognizes phospholipid and its associated proteins. It causes prolongation of the APTT. However, this effect can be overcome if excess phospholipid is added to the test system. In other words, there would be less prolongation. 3. The severity of hemophilia A is related to the degree of deficiency. Hemophilia A is due to the genetic deficiency of factor VIII. The inheritance pattern is X-linked recessive. Therefore, it is commonly passed from a female carrier to her son. Factor VIII inhibitors develop in 10 to 15% of hemophiliac patients because their immune system recognizes factor VIII as a foreign molecule. The severity of the disease is related to the degree of deficiency. 4. Thorough clinical history, APTT, PT, and platelet count are all considered part of the routine evaluation that screens for coagulation abnormalities. The thorough clinical history is the first and most important step in the evaluation of coagulation disorders and may provide important clues to the nature of the underlying condition. PT, APTT, and platelet count are routine, first-line tests that are done as part of the laboratory screening. A Bethesda assay measures the strength of an inhibitor. It should only be done after initial screening tests suggest the presence of an inhibitor. 5. Von Willebrand factor is collagen binding. Platelet GP2B3A receptor causes platelet aggregation. Thrombin causes fibrinogen activation. TPA causes the activation of fibrinolysis. Von Willebrand factor binds to collagen and platelet to facilitate platelet adhesion. Tissue factor interacts with factor VII to initiate in vivo coagulation. GP2B3A receptors allow platelets to bind to each other and mediate platelet aggregation. Thrombin cleaves and activates fibrinogen, turning it into fibrin. TPA activates plasminogen, giving rise to plasmin, which is the main effector of fibrinolysis. 6. Heparin is an injectable anticoagulant used to treat and prevent deep vein thrombosis and pulmonary embolism. Heparin works by binding to antithrombin 3, which is a natural anticoagulant that acts on multiple different factors on both sides of the cascade.
but it seems to have more of an effect on the intrinsic arm than it does on the extrinsic arm of coagulation. Heparin binds to AT3, causing a conformational change that activates AT3 and potentiates its action. Because heparin works quickly and is delivered by injection, it is most often used in a hospital inpatient setting and needs to be monitored closely to prevent bleeding episodes. PTT is used to monitor heparin therapy. The normal therapeutic range for heparin monitoring is 60 to 100 seconds. While PTT is acceptable for monitoring heparin by using an established therapeutic range, the anti-10A assay is preferred because it is direct measurement of heparin concentrations in the blood. Currently, specimens for anti-10A analysis are sent to the University of Washington Coagulation Lab. 7. A half-filled blue top tube is not acceptable. When properly filled, the ratio of whole blood to citrate anticoagulant in the test tube should be 9:1. If the tube is not full, there is an excess amount of citrate relative to plasma. As part of clot-based tests, calcium is added. If too much citrate is present in the tube, it will bind the calcium that is added to start the test, resulting in a prolongation of the clotting time. 8. With a PT of 18.6, which is greater than the reference range of 11 to 15.5 seconds, and an APTT of 45, which is greater than the reference range of 22 to 35, the least likely condition is isolated hemophilia A, because there is prolongation of both PT and APTT. This could be seen in multiple factor deficiency due to increased synthesis of functional coagulation factors, in liver disease, warfarin therapy, or vitamin K deficiency, or increased consumption, e.g. in disseminated intravascular coagulation. However, hemophilia A is a deficiency of factor VIII, which is involved only in the intrinsic pathway. Isolated hemophilia A causes prolongation of APTT only. The PT should be normal. 9. Factor VIII inhibitor causes severe bleeding. Protein S deficiency, antithrombin deficiency, antiphospholipid antibody or lupus inhibitor, and protein C deficiency all are associated with increased thrombosis. 10. The 1-to-1 mixing study, which is often done to differentiate factor deficiency versus inhibitor. The patient's plasma is mixed with normal pooled plasma at 1-to-1 ratio, and the PT or APTT is measured to see whether there is correction of the prolongation. Lack of correction suggests the presence of an inhibitor. However, the assay does not identify the specificity of an inhibitor if one is present. Prolonged incubation helps to identify slow-acting inhibitors such as factor VIII inhibitor. 11. In an elderly patient without any bleeding history but has a prolonged APTT and a normal PTT, the most common etiology is the lupus inhibitor. Liver disease, warfarin therapy, and disseminated intravascular coagulation cause multiple factor deficiency and would prolong both the PT and APTT. Factor XII, like lupus inhibitor, causes isolated prolongation of APTT. However, this entity is relatively rare, and in an elderly patient, a lupus inhibitor is much more common. Factor XII deficiency is also associated with much more dramatic prolongation of the APTT. The current case only shows mild to moderate prolongation of the APTT. 12. Thrombocytopenia is a condition in which a patient shows markedly decreased platelets. Anemia is a decrease in red cells. Thrombocytosis is an increase in platelets. Von Willebrand disease or aspirin effect do not have any morphological findings on the peripheral blood smear. 13. The aspirin effect is the most common cause of a qualitative or functional platelet defect. Glanzmann's thrombasthenia, Bernard-Soulier's disease, and various storage deficiencies are inherited functional defects associated with defective platelet adhesion for Glanzmann's, aggregation for Bernard-Soulier's, and activation for storage deficiencies. However, these qualitative disorders are quite rare. Thrombocytopenia is decreased platelets and is a quantitative disorder of platelets. Aspirin inhibits the cyclooxygenase enzyme in the platelets and inactivates the platelets. Because aspirin is widely used, aspirin ingestion is the most common cause of a functional platelet disorder. 14. Vitamin K is the factor that facilitates the gamma carboxylation of various coagulation factors. The carboxyl group allows these factors to bind to a phospholipid surface with the help of calcium ions. 15. The vitamin K dependent factors include coagulation factors, factors 2, 7, 9, and 10, as well as protein C and S. The latter two inhibit factor 5A and factor 8A, thus they are anti-clotting factors. Vitamin K is abundant in green leafy vegetables. Newborns are often deficient in vitamin K. Vitamin K deficiency and warfarin therapy have similar effects on coagulation factors. With severe deficiency, both PT and APTT are prolonged. 16. Factor 7 is involved only in the extrinsic pathway and causes prolongation of the PT only. Heparin therapy, factor 9 deficiency, lupus inhibitor, and hemophilia A are all associated with isolated prolongation of APTT. 17. TPA activates plasminogen and fibrinolysis. Protein S is a cofactor of protein C. Heparin is an anticoagulant that potentiates the action of antithrombin. Von Willebrand factor binds to factor 8, stabilizing factor 8 by serving as its carrier protein. Warfarin inhibits synthesis of all vitamin K-dependent factors and does not interact with antithrombin. 18. An acceptable specimen for coagulation studies should be in a blue top citrate tube that is completely filled and without clots or hemolysis. The citrate buffer maintains the pH and binds to the calcium 2+ ions, which prevents premature activation of the coagulation cascade in the test tube. A half-filled test tube will erroneously prolong the clotting time. In a clotted specimen, there is significant consumption of coagulation of factors. Hemolysis may cause premature activation of the coagulation cascade. This will also render test results unreliable. 19. You have an elderly patient with a history of new onset of bleeding and an isolated prolongation of APTT that fails to correct on a 1-to-1 mix, but shows further prolongation after 1 hour of incubation. These features are very characteristic of factor 8 inhibitor. The factor 8 activity measured at the 1.5 dilution is low, which is expected in the presence of a specific factor 8 inhibitor. Factor 9 and factor 11 levels are determined by APTT-based clotting time assays. Because the APTT is prolonged by the factor 8 inhibitor, the apparent activity levels of factor 9 and factor 11 are also low. This may mislead one to believe that there is a multiple factor deficiency. However, if the factor levels are repeated at higher dilutions, the factor activity levels would increase because the inhibitor is diluted out and weakened. The activity levels of factor 9 and factor 11 should rise even faster than that of factor 8. 20.
Heparin potentiates the action of antithrombin. Lepirudin and argatroban are both direct inhibitors of thrombin. Warfarin inhibits vitamin K-dependent synthesis of coagulation factors. Aspirin inhibits platelet function but does not inhibit fibrinogen.